Good afternoon, and thank you for joining us today for our Awareness Series presentation. My name is Kayla Rogers, and I'm an Education and Outreach Coordinator with the Women's Fund. For those of you who are not familiar with our organization, we are a not-for-profit in Houston, and we provide health education to women and girls. And we do this through focused seminars like today's presentation, as well as curriculum-based classes and publications. So our presentations, programming, and publications are all free. If you're interested, you can visit our website. I've put a link here and a QR code to our publications page where you can download PDF versions or submit a publication request for physical copies. So we are very excited for today's presentation. I just want to go over a few housekeeping things beforehand. If you have any questions at any point, please feel free to add them into the chat. We will have time at the end of the session for questions and answers. So at any point, if you're like me and you are not going to remember at the end of the presentation, you can put the question in the chat at any point. It may just not be addressed until the end of the presentation. We ask that you remain on mute until the end of the presentation when we're asking questions and answers, just to minimize any disruptions during the presentation. So today our presentation is Immunizations in You, and we are going to be hearing from Dr. Melanie Mazzoon. So we've had the pleasure of working with Dr. Mazzoon numerous times. She always does such a wonderful job. And so I'm definitely looking forward to this presentation. Before I turn the floor over, just a brief introduction. So after earning her medical degree in 1982 from the University of Texas Health Sciences Center at Houston and completing her pediatrics internship at the University of Kentucky in 1983, Dr. Mazzoon returned for her residency at the University of Texas Health Sciences Center at Houston, finishing in 1985. Dr. Mazzoon speaks Spanish and Farsi, and she is the managing physician for immunization practices at Kelsey-Seybold Clinic. She is a member of the Texas Pediatric Society, Houston Pediatric Association, International Society for Travel Medicine, the Immunization Partnership, and the American Academy of Pediatrics section on breastfeeding. She's also a fellow of the Academy of Breastfeeding Medicine. Dr. Mazzoon is married with 2 grown children. She enjoys gardening, sewing, tutoring adult study groups, and teaching children's classes. So Dr. Mazzoon, we are so grateful to have you here today, and I will turn the floor over to you at this time.
Thank you so much. So I'd like to start talking about immunizations actually with talking about infection, because most immunizations are against infections. And if you'll put up the first slide, there are 2 broad categories of infections that people encounter. The first is viral infections, and the second is bacterial infections. And it's important to understand how these infections affect our bodies, because you can often self-diagnose a little bit and know whether you need to go to a doctor based upon what kind of symptoms you have. Because as you know, viruses, there are very few antiviral medications. We do have some for COVID and some for a few other viruses. And more often than not, antibiotics are our only choice for bacterial infections. They don't work well for colds and other viral infections. So viruses don't have the ability to duplicate themselves or replicate themselves. They, in that sense, are not truly alive. They have DNA or RNA, and they can reproduce only if they can find a cell to latch onto, so that they can hijack that cellular machinery and then reproduce themselves. So they live on, they exist on surfaces for long periods of time, or float around in the air for long periods of time, doing nothing except waiting around to find a cell to latch onto so that they can reproduce themselves. And when a virus infects us, because it first infects 1 or 2 cells and then reproduces itself in great numbers, those new viruses then infect other cells in our body. And pretty soon we go from 1 or 2 infected cells to our whole body feeling bad. So they make us have, body aches, fever, just general malaise, sometimes rashes all over our body, for example, chickenpox or measles rashes. So viruses are sort of a whole body infection. And when we make a vaccine against viruses, some of our early antiviral vaccines were live virus vaccines, and they're still in use because they're very effective. For example, the measles, mumps, and rubella vaccine, yellow fever vaccine, smallpox vaccine, which we don't even use anymore, and a few others. Rotavirus vaccine is another notable one. So those are live vaccines, and they produce immunity by causing a weakened form of the infection, a very much weakened form. And other types of vaccines for viruses are just copies of the virus's protein coat. So our bodies have this really interesting ability to detect non-human proteins and to develop immunity. So when that virus infects your system, your body immediately goes to work saying, hey, I don't like this protein. It's not part of me. It's not, it's not part of my body. It's not something that my cells are supposed to be making. And it will produce immunity to that protein called antibodies. And those antibodies then can attach onto the virus's protein coat and prevent it from latching onto your cells. Next slide, please. Bacteria, can you advance the slide, please? So bacterial infections are different. Bacteria are alive. They can reproduce themselves without mammalian cells or human cells or other animal cells. But our bodies instead are providing a nice warm place to grow and a source of food and water for them to thrive. So bacteria tend to land in your nose or throat and cause just tonsillitis or just sinusitis. They tend to be more localized infections. Pneumonia and meningitis are other infections that are bacterial, urine infections. And so they're just local infections. That's why when you get an abscess, or even a pimple, it tends to be one spot, not your whole body that feels bad. So it's just one spot. There is the opportunity, particularly in people who have immune compromise, for bacteria to spread throughout the body because the body is lacking the ability to localize that infection and wall it off. So sepsis is the term we use for that. So you've heard of people dying of sepsis. Those are generally people who started with an infection in one spot, for example, a urinary infection, and then their body lost the ability to wall it off and keep it in one spot, and it began to spread through the bloodstream. Most vaccines against bacteria are copies of the bacterial protein coat and are not live. There's only oral typhoid vaccine is the only live bacterial vaccine that we use with any regularity, and it's a traveler's vaccine. So next slide, please. So this ability for your body to recognize the foreign proteins, I tell people all the time, is a little bit like your ability to recognize a firefighter by their, yellow jacket with the reflective stripes, or me as a doctor with my white coat. Once you can recognize the coat of something that doesn't belong in your body, you have the advantage that you can quickly eliminate it from your system before the infection takes hold. So this situation is, if you're vaccinated, your body already sort of knows the play. It knows what's coming up. So if you've been vaccinated, for example, against the hepatitis B viral protein coat, when that virus enters your body recognizes that it's an enemy, and it immediately calls forth the antibodies that it produced on its exposure to the vaccine. And those antibodies latch onto that viral protein coat and prevent the virus from entering your cells. So there's been we've been hearing a lot about this Delta variant of the COVID. I'm going to go a little off topic here because there's so much in the news about vaccine these days. We've been hearing about this Delta variant of the COVID infection. And what has happened with that is that protein coat, that spike protein on the COVID virus, has changed just enough that the antibodies, while they can still cover it and prevent the virus from latching onto most cells. Occasionally, the antibody is not a good enough fit, and that virus can still infect some cells. And that's particularly true in the nasal passages. And that's because when you get a shot in your arm, you're producing immunity that is primarily in your bloodstream and circulates throughout your system. When the virus enters your nose, because you're talking face to face with somebody who is asymptomatic and carrying it, you breathe that virus in, and it first enters through your nasal passages. And vaccines are good at creating a certain kind of antibody called IgG in your body, but a little less effective at creating IgA antibodies, which are the ones that coat our nasal passages and our gastrointestinal tract and our lungs. So that's why, because this variant is a little bit different, and because the protein is not exactly the same, our immune system can still fight it off in most cases, but it's not so good at fighting it off in the nose, and it may not fight it off completely because the protein has changed a little bit. And that's why the vaccine manufacturers are working on producing vaccines against the Delta variant and against other variants. So how do they produce these COVID vaccines or these messenger RNA vaccines? That's a newer version of vaccines. Most of our older vaccines, as I said, are live virus vaccines, or they are just copies of the protein coat. For example, the human papillomavirus vaccine, HPV against cervical cancer, and the hepatitis B vaccine. Those are produced actually in Baker's yeast cells, where the yeast has been modified so that it just produces little pieces of protein that look like hepatitis B virus surface proteins or look like papillomavirus surface proteins. The messenger RNA vaccines, which have been in development over the past 20 years and were primarily being developed for anti-cancer vaccines, these actually use a little piece of messenger RNA to have your own cells produce the protein that you become immune to, which sounds a little bit tricky because it is. So messenger RNA is kind of like a stencil. Your DNA is your genetic material. Messenger RNA is not your genetic material. It's a stencil or a copy of a little segment of DNA that is used for making protein. So the nucleus of your cell has the DNA, and the messenger RNA is created to copy just a segment of your DNA to take it over to the cellular machinery that makes proteins, and just transfer the information on what kind of protein needs to be made today. So you use that same messenger RNA platform, or that ability is used to make all the proteins of your body. It's used to make the keratin of your fingernails and hair. It's used to make the hemoglobin in your bloodstream. It's used to make the myoglobin in your muscle cells. It's basically used to make you out of your DNA, or from the blueprint of your DNA. And so messenger RNA has a very, very short lifespan, and it has that short lifespan because if it didn't degrade and fall apart quickly, you would make too much of the proteins that your body needs. So you would have overgrowth of your skin keratin and way too much hemoglobin in your bloodstream, et cetera. So it's by natural design that mRNA or messenger RNA falls apart pretty quickly. It's a fragile molecule. It doesn't last very long. So this messenger RNA that's in the vaccines is coding only for the spike protein. And all they needed to know in order to make this messenger RNA molecule was really what protein they wanted to target. So now that they know that the Delta variant is more contagious, they can actually produce a new vaccine that will target that. So far, it hasn't been necessary to come out with that vaccine yet, because the current vaccines are still holding up very well, preventing hospitalizations and death, particularly in people who have a good, strong immune system. But some people will have breakthrough infections, and some people whose immune systems are compromised by medications they're taking, for example, steroids, or illnesses they have, for example, HIV/AIDS, those individuals may not produce good immunity even given the vaccine. And so just this week, well, just within the week, we have started offering additional doses of the messenger RNA vaccines to people who have immune compromise. And that's a little different than a booster dose. We're not trying to boost their immunity as much as we are trying to give them a third in their primary series. So you know that we immunize little babies, for example, with 3 doses of many of their vaccines, and that's because they also have immune systems that are not fully functioning yet. And so sometimes it takes extra doses to develop sufficient immunity. And that's what's being offered now to people who are immune compromised, not really a booster, but an additional dose because they may not have responded to the first 2 doses the way a healthy person would. So once our body makes these little proteins on the template of the messenger RNA, those proteins are then visible to our immune system in cells called dendritic cells, and they are presented to our lymph nodes where we make antibodies to them. And so we sort of create our own vaccine because of this messenger RNA. We create the protein. Most older vaccines are the protein itself, whether it's from a live virus, a killed virus, a portion of a bacteria, or a copy of the virus's protein. But in this case, we're making the protein ourselves within our body. And the antibodies work in the same way, the same natural way to protect us. Next slide, please. Can you change the slide? There we go. So, so the lymph nodes then produce these antibodies, and these antibodies, I like to talk about this kind of like a lock and key. So the protein on the surface of the virus sticks out a little bit like a key, and generally it will fit in some sort of receptor on our cells, which is like the lock. And the COVID virus, for example, fits on what's called the ACE receptor, which is a very important receptor on our cells that controls things like blood pressure and signaling between one part of our body and another. So if the key fits into the lock kind of loosely and has to be jiggled and might fall out before it really turns that lock, then the viral particle can't stay latched on and can't reproduce itself. If the key fits really securely and turns the lock right away, then it's very easy to get infected. So the better that protein fits the receptor on the cell, the better the viral protein fits the receptor on the cell, the easier it is to cause an infection, the fewer viral particles it takes to cause an infection, and the more cells in your body get infected with any given number of viruses that you're exposed to. So it's both more contagious and it makes you sicker because that fit is better and because it can attack more cells all at once. So that's the situation with the Delta variant, for example. It just fits our cells better than the earlier ones. It takes fewer viruses to make us sick, and it doesn't fall out of the lock very often. So it infects a lot more cells with a lower dose. The antibody tags actually attached proteins, and they're kind of like if you took a key and put tape over it, you know, it wouldn't fit into the lock anymore. It wouldn't open the door anymore. And so these antibodies basically bind to the proteins on the virus and make it impossible for the virus to latch onto a cell and cause an infection. Again, with COVID, you're missing the antibodies. You have fewer of these antibodies in your nose. So those who get infected with the Delta variant, for example, don't have as good a protection in their nose as they have in their bloodstream. So they're more likely to be an asymptomatic carrier and shed the virus from their nose than they are to get sick enough to cause a fever or to feel bad all over, like the virus has already entered their bloodstream and gone throughout their body. I'm trying to get, there we go. I have a sidebar that hides part of the slide from me. So there's a second kind of immune cell called a T cell. The antibodies are made by B cells, and the T cells are a second kind of immune cell that helps us protect against viruses, and they induce long-lasting immunity. So T cells remember how to make the antibodies, and instead of just producing antibodies that are around in your system all the time, they have a long-range memory so that if you're infected in the future, they can ramp the system back up. And so activation by vaccines is very important to produce long-term immunity. So you're hearing now, for example, that some of the immunity is starting to wane from the initial COVID vaccines. And upcoming in the news will be information about some people possibly needing boosters. And a booster is given usually months after an initial series of vaccines to remind your immune system that it needs to stay tuned up to fight off this virus. So it's expected, and in fact, it's coming out in the news today, it's expected that healthcare providers and people in nursing homes, the elderly, that many populations who are at higher risk may need booster doses of this vaccine, particularly because we don't have the new version against the Delta yet. And that will just help maintain a long-term memory. For many vaccines, just getting that second dose will make the long-term memory. And that's what was originally thought when we started out, and we have these 2-dose vaccines. The Moderna and the Pfizer would have the first dose would activate the B cells and produce antibodies, and the second dose would activate the T cells and produce long-term immunity. And it is true that a lot of long-term immunity still exists. That's why people are not getting hospitalized if they've been vaccinated. They're not getting as many people hospitalized and dying from COVID. But there's a concern that in certain groups that immunity will diminish over time. And so these boosters are going to be recommended pretty soon, I think, in the United States. It's a little unfortunate that that's the case. If we could have gotten everybody immunized, we would have really dampened down the number of people transmitting this virus and reduced both the number of variants and the number of people who would need boosting. And it's a little unfortunate too to be offering a third dose to people here when there are huge parts of the world that haven't even gotten a first dose. So, but we have to remember that it's likely that we're going to need to come out with vaccines addressing these variants and offer those to the rest of the world as well. So I know I'm supposed to be talking about all vaccines. And so all of this information is pretty applicable to all vaccines, but I know COVID vaccine is what we have mostly in our brain right now. So this information is very valid for example, the measles vaccine, which we do boost. We give it to 1-year-olds and then give it again to 4-year-olds, and other vaccines that we give more than one dose of. And so that's true. For example, that's why you need your every 10-year tetanus booster, and why kids who get the meningitis vaccine at 11 need it again at 16 before they're headed off to college. Next dose. Next slide, rather. Next dose. Listen to me. Okay. Here we go. So because your body gets this vaccine, it is immune to the protein before it has an exposure to the real germ or virus. And basically, it's kind of like a football team getting wind of what the plays are that the opposing team is going to use in the game. It gives us an advance notice of what might be coming so that we're prepared and we can fight off the infection much more quickly. Reactions from vaccines, like, almost all vaccines will make you sore at the injection site and may cause low-grade fever. When you have a reaction to a vaccine, it's really a sign that your immune system has paid attention. So while they're bad in the sense that they make us have a sore arm or a low-grade fever and we don't feel too great possibly for a couple of days, they're good in the sense that we know that our immune system took notice. Just as a personal example, I was in the AstraZeneca trial, and when you're in a vaccine trial, you don't know if you're getting the vaccine or the placebo, which in that case would have been saline that wouldn't cause any symptoms at all, because saline is a normal body component. Basically, it's just salt and water. And so I was so happy that I got chills and low-grade fever the night after my first vaccine and a sore arm after the second vaccine, because even though I wasn't supposed to know whether I got the vaccine or not, I was sure I had gotten the vaccine. So you should be happy when you have a reaction to your vaccine. And many of the newer vaccines cause a lot more of a reaction than older vaccines because they are more effective. For example, the shingles vaccine that we use now has what's called an adjuvant in it. It's just a compound that makes your body really pay attention to the vaccine component of that vaccine, and it ramps up your immune system's response. And so the current shingles vaccine is about 99% effective, whereas the former shingles vaccine was only about 50% effective, 50 to 60% effective. So you're trading off one thing for another. You're having more local side effects, more systemic side effects from the injection, but you're getting much better immunity. Another example of that is with whooping cough vaccine. So when my kids were little, when my son was little, he got the whole cell whooping cough vaccine, which we knew as pediatricians would cause fever and sore legs, particularly the fourth dose, the booster dose in 18-month-olds often caused quite a lot of fever and sore leg and fussiness and irritability. Well, they came out with a newer version that they thought was going to cause just as good immunity with fewer side effects. And we have learned over the intervening 20 years that actually the immunity from the newer version doesn't last as long. And it truly doesn't cause as much fever and reaction, but it doesn't cause as good of an immunity over the lifespan of the child. So it's sort of a good, like I said before, a good news, bad news thing. If you have a vaccine that causes a lot of a reaction, that means your immune system is working and that you're likely to have long-term immunity. Whereas if you don't have much of a reaction, you should be concerned actually whether you got a good immune response to that vaccine. Live virus vaccines reactions can be delayed a bit because it's a live virus. So the measles virus vaccine, for example, does cause a very mild case of measles. And going back to my example of, I'm a doctor because I'm in a white coat. The live virus vaccines are sort of like the white coat without a doctor inside, or maybe actually the protein coat ones like hepatitis B are more like the coat with no doctor inside, but the live ones are like the coat with 5-year-old Dr. Mozoon inside. I wouldn't be much good to you. I wouldn't be able to be much of a doctor, but you'd still recognize the coat and I would still be alive. So they are weakened so that they can't cause serious infection, but they still replicate in your body and do cause immunity because they're around for a while. And so those reactions occur usually about a week out from the vaccine because the virus has to cause a little bit of an infection before it takes effect. Next slide. So why do babies need so many shots? Gosh, there we go. First of all, babies are born with a really competent immune system, but not much history of exposure. So the womb is pretty much sterile, and they have some immunity passed through the placenta to them. And that immunity is to basically every infection and every vaccine that their mother has ever gotten. The best immunity is for recent infections or recent vaccines that mother has gotten, which is why we recommend the whooping cough vaccine for mothers in every pregnancy to help protect the baby until they can get their own vaccines. But the baby themselves has not been exposed to any germs or viruses that could make them sick. And so they don't really have that playbook as to how to fight those infections off. And as soon as they are born, they're exposed to just really thousands of different kinds of germs. Some of them are good germs, some of them are bad germs. So they get some good germs that are going to line their intestinal tracts, particularly from breast milk and colostrum. And they get some bad germs. Perhaps mother has had group B strep isolated from her vagina. It's a screening test that we do to try and prevent infections in babies. And maybe she had a bladder infection with that germ, for example. And those could make the baby sick. Some infections are worse if you're small than if you're large. So we've all heard recently about RSV infections in a lot of kids this summer, which are rare in the summertime and more common in the wintertime. RSV tends to cause inflammation of the airways. If you have a very small diameter airway and you get 1 millimeter or 2 of swelling on the inside of that airway, it basically plugs it off. If you have a larger airway, an adult size airway, 1 millimeter or 2 of swelling doesn't cause much more than a little bit of a heaviness in your breathing, and it doesn't really plug off whole areas. So the smaller your body is, sometimes the infection can be worse just simply based on the size of the person who's being infected. Children often get exposed to illness more often than adults. Adults have this whole lifetime history of things that they've had, and they're more protected against basically colds and flus and other infections because they've had many of them over their lifespan. So they have some immunity and some protection to most of the things that will cross their paths. And that's not true of children. And then we cluster children together in daycares and schools. And so those clusters tend to spread things around, particularly the stomach infections like rotavirus infection and respiratory infections, because children also have very poor hygiene and babies have very poor hygiene. And, we're constantly changing diapers, washing our hands. It's anybody who's taking care of a little baby, it's like, how many times do I have to wash my hands today? Because I wash my hands, I feed you, you poop, you pee, I have to clean you up, I have to go back and wash my hands. Pretty soon you're hungry again. It's a constant battle to keep that exposure down. Some of our immune capabilities mature with time. So there's some infections that are very uncommon in adults, like Haemophilus influenza bacterial meningitis, but the babies are very vulnerable to those infections. And so our vaccines are given to babies more than adults because they just have these exposures, and the illnesses are worse in them. So babies are more prone to meningitis when they get a bacterial infection. They're more prone to pneumonia when they get a bacterial infection. And so we have a whole series of vaccines, which looks excessive to people who are concerned about how many pokes that their baby is going to get to become immune. But in fact, we're doing our best to immunize babies against illnesses that could kill them or cause severe disabilities in them that could be lifelong. Meningitis not only kills, it causes permanent deafness in many children, or mental retardation, for example. So when we give vaccines to children, we know that they need these vaccines. We know the youngest age at which these vaccines are safe to give, meaning they're not going to make us think that the child's been infected because of the reaction they get. And we know that they're effective, that they're going to cause immunity for that baby so they are less likely to get infected. So we give all of our vaccines at the youngest age at which they're both safe and effective. That means that hepatitis B vaccine is offered at birth. Birth is a bloody experience, and moms who are positive for hepatitis B transmit that to their babies during the birth process. And we check all our moms for hepatitis B, but hepatitis B can also live on surfaces for up to 3 weeks. And we can't check all the dads and grandparents and babysitters and housekeepers. Hepatitis B is like I said, a blood and body fluid-borne virus. And about 1/3 of the people who have it don't know that they have it, and 1/3 of the people who catch it don't know where they got it from. So it's often a question in the hospital, why are you giving a hepatitis virus vaccine to my newborn baby? And it's because sometimes the test on mother was reported wrong or transcribed wrong. Sometimes somebody else in the family may have hepatitis B. And this is actually our first anti-cancer vaccine. Newborns who catch hepatitis B get chronic liver infections that lead to cancer or cirrhosis. So down the line, you need a transplant or you die from this illness. if you catch it as a newborn. So it's very important to protect newborns from infection with hepatitis B. And we know that that vaccine is as safe and effective in a newborn as it is in an adult. We've been giving this vaccine to newborns since 1992. I know that because my youngest child was born in 1992 and got it in the hospital that first year that it was offered then. So next slide, I'll go on to the next slide. So we give all these vaccines at the youngest age at which they're safe and effective. So most other vaccines are started at 2 months of life. And at 2 months, we give a number of different vaccines because so many of them are effective at 2 months. And so many of these illnesses are very serious the younger you are. And fortunately, we have combination vaccines. So some parents are actually worried about combination vaccines and ask for vaccines to be spread out or delayed. We know that there's no advantage to spreading out vaccines. When you spread out vaccines, you're actually delaying protection. And you know, it's hard to pick, like, which one am I going to delay? Am I going to delay giving protection against polio, or am I going to delay giving protection against meningitis? You know, they're all serious illnesses. And so delaying protection against any of them is a bad idea. So there are these newer vaccines. We currently have a vaccine available at Kelsey-Seybold that gives 6 different vaccines all in one injection for the baby. They still need their oral rotavirus vaccine and they need a pneumonia vaccine, Pneumovax, but all the other vaccines are in one injection. And so that's a real advantage to babies. We know that when you spread out vaccines, you're basically causing more stress to your baby. So you're bringing the baby back every week or two to get caught up on their vaccines, and you're just making them go through the stressful experience of getting a shot over and over instead of doing it all at once. And that's actually been measured. So you can measure stress hormones in saliva, and it's been measured in babies. And, you know, for babies and adults, getting 1 shot is maximal stress. We all stress out about shots. It's a little painful to get poked with a needle. None of us like it. And the amount of cortisol and adrenaline that people put out with 1 shot is the same as the amount that they put out with 5 shots. It's a maximal stress. It's, you know, it makes us unhappy, but it's over with very quickly. And then our hormones go right back to a normal level. So there's really no good reason to spread out vaccines or to delay the series of vaccines until the child is older. I tell parents, you know, who want to delay their vaccines, I think about this as a preventative measure. It's like your child's car seat. You know, if you told me, oh, okay, I believe in car seats, but I'm not going to start putting my child in a car seat until they're 6 months old, I'd think you were crazy, because you could have a car accident before your child is 6 months old and that child could die. Well, the same is true for those who delay vaccines. You might perceive that by delaying the shot, you're preventing the child from having a sore leg or a poke or, you know, something unknown being injected into their body. But in fact, what you're really doing is delaying protection against something that could kill them before you decide to get the series started. So it's never a good idea to delay vaccinations. They should be taken on the schedule that we recommend, because that's what's been studied. And in fact, with all of those different vaccines that we now give, we actually are administering fewer protein antigens than they're in the entire series than were given to kids in the 60s, because we have gone from, you know, giving vaccines that were a whole dead bacteria to just a few proteins off of that bacteria's coat, or a whole dead virus to just a few proteins off of that viral coat. So we've gotten much more specific with our vaccines, and you get a lot more antigens, which are the non-human proteins. You get a lot more antigens with one bacterial throat infection, for example, than you get from a series of vaccines as well. So this is not stressful to their immune system. Their immune systems are competent to deal with it. And we really recommend that all vaccines be given on the schedule that the CDC and the American Academy of Pediatrics recommends, because that's the way to protect your child against illness the most safely. Next slide. Catch my breath. I don't know why I get a delay on my slides. So here are the recommendations. So children get 3 doses of hepatitis B vaccine, which is, as I told you, a blood and body fluid-borne virus that is more common in the US than AIDS. Rotavirus, which is a very serious kind of stomach flu that causes both vomiting and diarrhea simultaneously, and kids get dehydrated and can decompensate and die from that, or need to be hospitalized and get IV fluids. Diphtheria, people don't know much about. That's actually a kind of a sore throat that causes a curtain, a membranous curtain on the back of the throat that makes it impossible to breathe. So kids choke to death from diphtheria because this membrane covers their airway. And diphtheria is actually, diphtheria toxin was actually the reason for the Iditarod dog sled race up in Alaska, where it recapitulates a historical time when dog sleds were used to deliver diphtheria antitoxin to save children in remote Alaska. So that's an interesting aside. Tetanus, of course, everybody's heard about tetanus, and you know that you can catch it from a rusty nail. But if you've not seen tetanus, tetanus is a horrible illness. It causes severe muscle spasms. I know all of you have had a bad cramp in your calf or a cramp in your wrist and hand that was extremely painful. Well, just multiply that by cramps in all of the muscles of your body that last for days, and you'll understand why you wouldn't ever want tetanus. And actually, tetanus is one of those illnesses that people often are under immunized for. So if you are an adult over the age of 25, you need to be checking to see if you've had your tetanus booster in the last 10 years. Fortunately, it also now can be given along with the pertussis or whooping cough booster. So we do a lot of recommending of that vaccine for pregnant women and for grandparents who are going to be around a newborn, so that they'll have the protection of the whooping cough so they don't give whooping cough to the newborn. But tetanus vaccination levels are pretty low across the US in adult populations. People forget to get that, and their doctors forget to offer it to them. And a lot of healthy young adults don't go into the doctor every 10 years, much less more often than that. So pertussis is whooping cough, and that causes such thick secretions. It's not a membrane like diphtheria, but it causes really thick secretions that are difficult for babies to cough out of their lungs. So they have this what's called a whooping cough, where they cough, and they can't breathe in. They're coughing out all of the air in their lungs, and they can't get a breath in. They can't stop coughing to clear their airway enough to get a breath in. So when they finally get their airway clear, they go like that, because it's been so long since they took a breath, and they turn blue during that period. And often babies will just completely stop breathing from whooping cough. So it's much more dangerous the smaller your airway is. In China, it's called the 100-day cough because it lasts 100 days. Even in adults who catch whooping cough, they will be coughing generally for 3 months, and often break ribs because of the coughing. It's not a good illness. Haemophilus influenza type B is a bacterial meningitis. It's not even related to the flu. It got its name actually historically when they were trying to figure out what was causing the great influenza pandemic of 1918. They isolated this bacteria and thought it was the cause, but it was not. So that's where it got its name. But it causes severe meningitis, and it can cause throat infections called epiglottitis that can strangle kids and block their airway, as well as sometimes eye infections and cheek infections and sinus infections and ear infections. Pneumococcal vaccine comes from the word pneumonia, and that is a bacteria that causes not only pneumonia, but meningitis and ear infections. And since we started giving that vaccine, The rate of pneumonia in older people has gone down, even though we give the vaccine primarily to children, because children are such little transmitters of all kinds of illness. I was going to say cesspools, and then I thought that was pretty impolitic. So, but children are not very hygienic, and by immunizing children against pneumococcal illness, we've not only improved their health and pretty much eliminated pneumococcal meningitis in childhood, but we've actually improved the health of the elderly population and the adult population as well. Poliovirus. A lot of people ask about poliovirus, like, why are we giving poliovirus? There's no polio in the US. Well, there's still polio in the world, and airplanes are available to all countries, and people could bring polio into the US. And so it's still important to be immunized against it. It is, after smallpox, our likeliest candidate to actually eliminate an illness, because poliovirus only exists in the human population. It doesn't have an animal reservoir. So if we can ramp up the administration of poliovirus vaccine in the few countries in the world that still have wild type polio, we could actually eliminate this virus from the planet. The problem is that there are anti-vaccine sentiments in all countries, and you may or may not have heard, but many polio vaccinators in countries where people have strong anti-vaccine sentiments have been targeted and even assassinated for vaccinating children against polio because of mythology about the vaccine, causing infertility, or because people think that the vaccinators are in cahoots with, Western powers and are somehow a threat to their culture. So it's a kind of a sad state of affairs where something that, a disease that could be eliminated from the world can cause such disunity that people would actually target people that are trying to do the public good in that way. Flu vaccine is recommended for everyone starting at age 6 months. Here is a good example of, safe and effective. So we don't offer flu vaccine to kids under the age of 6 months because it tends to cause fever and make their legs sore, and it's not very effective until you're about 6 months old, probably because of maternal immunity crossing the placenta. So that vaccine is started at 6 months, and infants and children under the age of 8 get 2 shots the first year that they take the vaccine. And after that, it's 1 shot a year like the rest of us. And that vaccine is not terribly effective because the virus itself changes so frequently that it's hard to keep up with what the protein code on its surface looks like. And that's why we need a new flu vaccine every year. And so that all that information I talked about, the COVID vaccine and the variants, is relevant to flu. Measles, mumps, and rubella, 2 lifetime doses will provide you lifetime immunity. So we give those generally at 12 months and at 4 years. But if there's measles going around a community, it can be given at 12 months and at 13 months, and you're still done with it. Chickenpox is the same way, and there's actually an MMRV vaccine, so sometimes those are combined to reduce the number of pokes. Hepatitis A is a kind of viral hepatitis that's transmitted by what we politely call the fecal-oral route, and it's often a disease of travelers who eat, at street side cafes or the food trucks of the less hygienic parts of the world. But it's also present in the US, and we have had that imported in on some fresh vegetables. So you may have heard of, green onions or strawberries causing hepatitis A outbreaks. And also some homeless populations have really suffered from hepatitis A in recent years. So that's given in 2 doses to children and provides lifelong immunity. And then meningococcal vaccine, just like we give it to the older kids, some high-risk children will get meningococcal vaccine, for example, children who have sickle cell disease. And I've already spoken about the combination vaccine, so I'll move on. I think we're getting close to the end and almost ready for questions. Next slide. So the older you get, the fewer shots you get. So age 7 to 18, you're still recommended to get your annual flu shot. We give meningococcal vaccine to kids entering middle school. They'll get a dose on entry to middle school at about age 11 or 12, and another dose at 16. We give the tetanus booster. So this is a Tdap and DTaP, which was on the previous slide, are basically the same components, just different amounts of those components. So the Tdap has just as much tetanus as that initial series did, but a little less diphtheria and a little less pertussis. And then human papillomavirus or HPV vaccine is 2 doses if you start it before the age of 15 or 3 doses if you start it after. That's an anti-cancer vaccine, and it protects against many types of oral cancer, cervical cancer, anal cancer, and it's human papillomavirus is actually a wart virus. And so the vaccine that we give also protects against certain kinds of warts. It's not the same as the wart virus that most kids have on their fingers, but it's a relative. Meningococcal B vaccine. So the meningococcal mentioned at the top is MenACWY, which is 4 different types of meningitis, including the type that people need to be immunized against if they're going to Saudi Arabia for pilgrimage. And so it's used a lot in travelers' vaccinations. Meningococcal B is a type of meningitis that is just as devastating, but was much harder to make a vaccine against. And so it came out as a separate vaccine, and the vaccine has to be given in a little bit different way in terms of the way it's manufactured. So they haven't figured out how to combine those, but it's another type of meningitis. And both of those types of meningitis are those meningococcal germs can live in your nose and throat. So the reason teenagers are recommended to get these vaccines and college students is because they share sports water bottles, and they do, have a lot of sort of shared contact with each other, close quarters and stuff. So it can live for years in your nose and throat without causing you any illness, but you could transmit it to somebody, or you could get, say, a sinus infection or a sore throat with a virus that allowed it entry into your bloodstream, and that's when it causes meningitis. The meningococcal B vaccine, I think, is less routinely used. It says for high-risk groups here. It's certainly, both of these are recommended for people, for example, with sickle cell disease or no spleen or cochlear implants. But there's a little more variability in offering the meningococcal B vaccine, because for most vaccines, we want proof that they are not only safe and effective, but that if you give them to the whole population, you will save money for the healthcare system. And meningococcal B vaccine doesn't do that. It's a pretty expensive vaccine. It will protect your child for a number of years, but not lifelong. And so if there's a less uptake in use of that vaccine, because overall, this is not a real common infection, and some people see immunizing everybody against it as a waste of healthcare dollars, and other people see it as saving the lives of young adults. So it's a little bit contentious, and your pediatrician can advise you and have that discussion with you. Pneumococcal polysaccharide vaccine is recommended for kids with diabetes or asplenia or cochlear implants, kids who are at risk for pneumonia during their teen years, and then hepatitis A for catch-up. Next slide. That was probably way too much detail on all of those. So as we get into adulthood, we need to continue vaccinating. So we all, of course, need our COVID vaccine age 12 and up now. The slide is out of date. We want college students to get the meningococcal conjugate vaccine, the original one, and possibly get the meningitis B vaccine as well. Every 10 years, adults should get a Tdap booster. And I'm really a believer that they should get the version with the whooping cough in it every 10 years. We know that the immunity only lasts for about 7. You may not have a newborn grandchild right now, but you might have one before your next booster is due. So I recommend people get the Tdap every time. We do give tetanus shots when people have a tetanus prone wound after 5 years. So that would be a time you could get just the tetanus shot without the whooping cough. HPV or papillomavirus vaccine is recommended for teens and young adults up to age 26 who didn't finish the series as teenagers. And it's actually now okay to give up to age 45 for adults who would like that series. And generally, again, that's another discussion with your doctor whether you're at risk for HPV or not. HPV is, that virus is so common in the population, about 80% of adults will catch it in their lifespan, in their lifetime. But most adults will clear the infection before it can cause cancer. So that's why it requires somewhat of a discussion. Most people over the age of 26 have already caught several strains of HPV if they've not been vaccinated, and may well have already cleared them from their system. So the question of whether they need a vaccine or not just requires some more discussion with your physician about what your risks are for infection. Seasonal flu is annual, and hepatitis B vaccines should be given if you're in a high risk group. So people who are getting tattoos and people who are, have multiple sexual partners, for example, should consider hepatitis B vaccine. And then hepatitis A vaccine is primarily for travelers or people who have other certain exposures, not so much medical exposures. Hepatitis B, if you're diabetic and you are doing a lot of finger prick testing, it's recommended that you get the hepatitis vaccine because sometimes accidents happen with those sharps, and you might use somebody else's sharp or you might use somebody else's injection pen accidentally. And so and also diabetics are at risk of needing dialysis, and dialysis is a risk for hepatitis B as well. Next slide. Okay, I thought we were near the end. I don't know how many more slides we have. So vaccines are very effective at preventing disease, serious illness, but they're not 100% as we've seen. So most childhood vaccines are about 85% effective. The live virus MMR is about 98% effective if you've had 2 doses. Flu vaccines are less effective, but they do still prevent hospitalization and death. And it's interesting about flu vaccines is they actually, people who get flu vaccine are actually less likely to have a heart attack, which is sort of an odd stretch because it's not an anti-heart attack vaccine. But the truth is that flu is such a strain on people's system that as they're recovering from the flu, they are prone to get sinus infections or have heart attacks as an outcome from that strain on their system. COVID vaccines are still very effective at preventing hospitalization and death, but can't protect us against all illness from COVID because of those variants, and also because of people's variability in their immune system's responsiveness. So that's also part of the reason flu vaccines and childhood immunizations are not 100%. Is part of it is the vaccine, and part of it is your body's ability to respond. So if you look at an outbreak, I have this little outbreak situation there from a prior talk that was more focused on measles outbreaks. So in an outbreak of measles, for example, the one at Disneyland several years ago, because most people are vaccinated, you might find that the number of people who were vaccinated and got sick was the same or maybe even more than the number of people who were not vaccinated and got sick. But that's because if you have a vaccine that's 98% effective, and like the measles vaccine, and 1,000 people are 1,000 vaccinated people are exposed, you're going to have 2 times 10. You're going to have 20 people, or what is that? 2 times 10? Yeah, 20 people who get sick who were vaccinated. And because the population is highly vaccinated against measles, you might only have 5 or 10 who were unvaccinated who got sick, but it was all 5 or 10 who got exposed because measles is highly contagious. So it can be very confusing when you see that vaccinated people are getting sick. And that's the situation now with COVID. You're hearing about vaccinated people getting sick, but what you're not seeing is that they're not getting as sick, that the proportion of people who are dying from COVID who are vaccinated is a very, very low proportion, whereas the proportion of people who die or get hospitalized who've not been vaccinated is very high. So you've probably heard the figure that like 97% of the people in the hospital are unvaccinated right now. That means 3% were vaccinated, but they probably had immune systems that didn't respond very well to the vaccine due to age or due to underlying medical conditions. It doesn't mean the vaccine doesn't work. It means that no vaccines are really 100%. Next slide. Okay. Mine is really delayed. Every time you switch slides, it takes about 3 more seconds or maybe longer. So we keep vaccinating because these measles have not gone away. We have reduced them dramatically. There used to be about 4 million cases of measles every year in the United States. And now in a bad year, we have, a few hundred. And so it's really important to recognize that we have to keep vaccinating because there are places where these diseases are still rampant. And an example is that with the rise of the anti-vaccine movement, Europe saw a huge resurgence in measles with, France having 12,000 cases in 1 year and Israel and England also having tens of thousands of cases. And so it's really possible for measles to become reestablished in our country as well from vaccine refusal. And that's particularly pertinent right now. The COVID epidemic has kept parents from bringing their kids in for checkups. Kids haven't gone to school, so the school system is sort of our backup to make kids go get back into the doctor's office and get their vaccines because they're not allowed to enter school or to participate in school until their vaccines are caught up. And so we have a lot of children who've not been caught up on their measles vaccine. We have a lot of children who have not ever gotten a chickenpox vaccine. We have a lot of children who are behind on their booster shots and so are more vulnerable. So we are really at risk, even right now in the US, to have measles be reintroduced. So fortunately, there's still a lot of travel restrictions and people are still wearing a lot of masks, but measles is so contagious that there have been documented cases of the transmission of measles in an airport terminal where the person who caught the measles was in the airport terminal 2 hours after the person who had the measles left on a flight. So we know that measles hangs around in the air, measles virus hangs around in the air, much like the COVID virus can hang around in the air. And so it's really important to keep your children up to date to make sure that they get their shots on time and that they get all of their shots, that you don't pick and choose which shots you want them to get and which shots you think they don't need, because we are protecting not only your child, but our community by keeping vaccination rates high. Next slide. Finally, we're ready for some questions. I feel like I've been talking kind of ad nauseum, so I hope I didn't bore you.
No, absolutely not. This was very interesting. Oh, there we are over here, my video panel. Okay, so I'm going to go ahead and open up the floor for questions. Since we're a smaller group, if you want to unmute yourself to ask your question, you can absolutely do that. I know it's a little difficult typing it in sometimes. The first question is, my 12-year-old currently has shingles. She had the vaccine and she never had chickenpox. How can this happen?
So chickenpox vaccine is a live virus vaccine. Where is her shingles located? Is it on her arm?
No, her left leg.
Her left leg. That's really interesting. So she actually may not have got, well, So her left leg. So she got immunized probably as a 1-year-old and actually may have gotten it on her leg, right? Her left leg. Is that where she got the?
I'm
You
not
don't-
sure.
Yeah, I would bet that that's the case, because shingles in kids who have gotten chickenpox vaccine generally is in the limb where they got it, and is milder than shingles that you would get from a live chickenpox, from the real chickenpox. So chickenpox vaccine is a live virus vaccine. It's weakened, but it has the characteristics of regular chickenpox in that occasionally it can decide to take up residence in your spinal column. So shingles is a reactivation of a former infection, and it's usually reactivated by something that suppresses your immune system. So say you got the flu, or you are on a short course of steroids for asthma or something, that can make that virus kind of reactivate. So that's how it can happen. It's very uncommon to get shingles after chickenpox vaccine, but it has been reported. And if you wanted to report that to VAERS, the Vaccine Adverse Event Reporting System, VAERS.gov, you could do that, because it is one of the things that is kind of tracked and studied. The thing about having gotten the real chickenpox is the real chickenpox gets your whole body. So you probably remember from your own childhood getting chickenpox all over, everywhere. And so when you get shingles from the real chickenpox, you're at risk of getting it in your eyes. You're at risk of getting chickenpox, zoster pneumonia. You're at risk of having, it on almost any dermatome, which is like the nerve that comes out and spreads over a section of your body. When you get it from the vaccine, your only risk area is in the dermatome or the nerve distribution from where you got the shot. So she probably will never get it in her eye or any of the more serious places to get it, on her brain or anything like that. But she could, particularly if she has something that also suppresses her immune system, she could get it again in her leg. And recently the chickenpox, the shingles vaccine has now been approved for people who are at risk down to a younger age. And I'm not coming up in my brain with what that age is, but I think it's 18. So if she has another case of shingles, I would consider giving her that vaccine when she turns 18.
Okay. She had the meningitis shot the night before this happened. Would that have triggered this?
If you had told me 3 days before, I'd say yes, because her body would have had a chance to start reacting to the meningitis vaccine.
Okay.
The night before, it's a little iffier, just because, you start responding, but you don't usually, you don't wipe your immune system out very quickly. In fact, you're activating your immune system, so it kind of becomes more alert. So I think it's probably true and unrelated.
Thank you very much, Dr. Mazoon.
Sure.
Okay, so our next question from the chat says, what are some ways to increase confidence in and uptake of COVID-19 vaccines with the current amount of vaccine hesitancy?
No, I wish I knew the answer to that. The interesting thing to me, I have discussions with people who are opposed to vaccines all the time. In my role as a pediatric hospitalist, parents of newborns are hesitant about the hepatitis B vaccine, for example, and I have these conversations frequently. And usually people are getting their information from the internet, from social media, and they have typed into the search, window something like, do vaccines cause autism? And of course, if you type that in, you're going to get a whole lot of mixed information. You don't get scientific answers from a question like that. You get people's opinions, because the internet is loaded with opinions. So I think a big part of the answer to this problem is for people to understand that anybody can put anything up on the internet and they can make it look very valid and very real and very, scary. And so you shouldn't trust sites that are trying to sell you something. You shouldn't trust sites that are trying to make money off of their site, that are proposing alternative treatments, that are selling you books or lawyer referrals or anything like that. You need to start with a site you trust. So, start with your doctor's website. What links do they have? Start with, a children's hospital in your area. What links do they have about vaccines? And, where do those take you? Because if you just put in a question, you're going to get a mixed bag. And unfortunately, many of these anti-vaccine sites are titled something very official sounding, the National Vaccine Information Center, for example, which is not the National Vaccine Information Center, it's the National Anti-Vaccine Information Center. And so it can be very, very difficult. I think establishing trust with people, asking them what they've heard, trying to understand what their fears are, and trying to help them understand that, making a choice to not vaccinate is, asking to take a risk, because the viewpoint is, okay, I'm not going to take the risk of getting this vaccine. So helping them to understand that there is also a risk with not taking a vaccine. We all take risks every day we think nothing about. We get in the car and we head to work and we don't think about the risk that we're going to be in a car accident, but it could happen, And so there's so much that we do every day that's pretty high risk that we do without even giving it a second thought. And then when we really focus on it, it makes us phobic. So if I really did think about my risk of a car accident, every time I got in the car, I might stop driving, right? So we have to really understand that parents of young children are focused on this issue because their kids get shots and they want to learn about it. But often they're getting their information from sources that are not reputable. So helping to guide them to reputable sources, I think, is important. So start with encouraging people to find a site that they trust and that is a trustworthy site, and then follow those links rather than Googling vague questions.
Right. And I would also suggest that you invite them to things like this. The Women's Fund has done presentations over vaccines and immunization before with trusted physicians from the community. Kelsey Siebold also just did a presentation earlier this week. So there are other opportunities for you to kind of share these different events and presentations so that they can hear from trusted healthcare officials as well.
I think sometimes too, it's just that scientists unfortunately are scientists, and we're not very good at explaining things and making them feel relevant or feel the emotional impact of some story that you might have heard. So, stories and storytelling are a lot more visceral. We get a visceral reaction to them, and so I think a lot of healthcare providers need to learn how to explain things so that they're understandable, and to also learn to tell stories. And so sometimes I'll tell parents stories about these illnesses from my personal experience, like the twins I had who caught hepatitis B from their mother and both were dead by the age of 4. That's a relevant story, so hearing what might have been prevented.
Okay, so we have another question here. What do you think about Pfizer vaccine being available for children under 12 starting next month? Would you recommend to your patients to vaccinate children under 12?
So there are a lot of questions about this. So if it becomes available next month, which I hope it will, I definitely would recommend it. A lot of people say, well, kids are getting asymptomatic infections, they're getting mild infections, why vaccinate them against this illness? There are two main reasons. One is for your child's health, because there have been, over 300 deaths from COVID in children. It is not always mild. You don't know that your child's going to get the mild version. Flu is also relatively mild in most kids, but children die of flu every year, and the COVID vaccine is killing more kids than flu kills in a bad year. So I would vaccinate my child, and I would encourage you to vaccinate your child. The second is that while we have people who can be reservoirs for this infection, and that includes kids, and that includes continents of Africa and South America, while we have people who are still able to transmit and carry this infection, we will continue to have variants that improve in their ability to infect us. And so for the safety of all of us, the more people we can get immunized, the lower the transmission, the less opportunity for this virus to change further and become more infectious and more dangerous. And really the sooner we'll be out of this pandemic. This is already stretched on quite a long while, and there's really not a good end in sight unless we can get the big majority of the population vaccinated. Children tend to also not have very serious side effects from the vaccine. They have robust immune systems. So I wouldn't worry too much. We've all heard, oh, the vaccine caused this in a person or that in a person. And there are some side effects from the vaccines. There are some side effects that have been severe, but they're very, very rare. And it's much, much more likely that your child will have a COVID infection that is severe than that they would have a vaccine reaction that's severe.
So the next question is one that I actually asked before we got started, and that's about a recording for the Kelsey-Seybold presentation from Monday. So do you have any idea where that might be posted, when it is posted?
Yeah, it's going to be posted on the Kelsey-Seybold website. I don't know if it is yet, but I'm sure that you could ask to have a link to that for your website. So I would say in a couple of days when you post this, I'm sure that they would be happy to give you the link to post that. That was a conversation about, how do you safely send kids to school in this environment, where some schools can require masks and other schools are not requiring masks. And, there's all this political upheaval about who can and can't require masks. Basically, the overall outcome was, your kid should wear a mask no matter what the school officials say or uphold. And that I think that parents should unite and accompany each other in encouraging principals to require masks within their school. I heard of a school today actually that decided to make masks part of the dress code. So they got masking as a requirement without making it a mandate. It's part of the dress code. You have to wear a mask. And so I think that was a very novel and helpful approach for parents to think about. The AAP website, there's an AAP, I wish I had it right here, I don't. Healthychildren.org has a section on COVID in schools and how to keep kids safe. And it's got a lot of very useful advice.
Kayla,
Thank you.
this is Nan. I just wanted to let you know, I did talk to someone in marketing. They're editing that and they are going to post it. I should have a link that I can share with you very soon. If not today, probably tomorrow. And you could definitely get that out to your group.
Yes, thank you so much.
Sure.
Yes. Okay, and then final question here. Why was the original variant not affecting children, and the Delta variant is affecting them having severe symptoms? So I guess maybe why
Why are there so many
COVID
kids sick from the Delta variant?
from the Delta?
Right.
Yes.
So the original version was infecting children just as much as it was infecting adults, but this one is so much more contagious. So what we're actually seeing is a function of how many kids are actually catching it. So when the original version came around, it was say, 50% contagious. Well, now this one is like 100% contagious. So, it's just that more kids are getting it. So more of them are also getting sick. Roughly the same percentage of kids are getting seriously ill, but because there's so many more kids out there with it, then the hospitals are getting loaded up. And the other problem is that we have this respiratory syncytial virus going around, which can affect kids basically age 6 and under, and it actually can infect adults and older kids too, but it causes younger kids to be more seriously ill, and that sets them up to have what's called a co-infection. So if they are just getting over one virus and they catch the other, or they catch the two at the same time, then they get really, really sick, because both are respiratory viruses, and their effects are sort of additive for each other.
Thank you. Okay, Dr. Mazoon, I know I said that was the final question, but I always have one last question myself. And that is, if you could have each of us walk away with one message or one thing that you want us to kind of keep kind of at the front of our brain, what would that be?
Immunizations are safer than infections, and they take advantage of the same immune processes. Immunizations cause a natural form of immunity. There's nothing unnatural about immunizations.
Well, thank you so much. This was a wonderful presentation. I'm sure that we had some more comments or questions, but due to time, I kind of cut those off. But if you do want to send your questions to healtheducator@thewomensfund.org, we'd be more than happy to get those questions answered for you. I also have a survey link here. We would appreciate if you would take a few moments to complete the survey, let us know how we're doing, what things we could improve on, and additional topics that you would be interested in hearing about. I've also included a link to our website, thewomensfund.org, and our social media accounts, where you can keep up with what we have coming up next. We're currently working to secure a speaker for our September awareness series. So I encourage you to visit our social media sites and our websites to be kept in the loop. But I appreciate you all so much for taking the time out of your day to be here. Again, Dr. Mazoon, it's always a pleasure working with you. We really appreciate you giving us this wonderful presentation and this information. And I hope that everyone here shares something that they learned today with others. Thank you all so much. And I hope you have a great rest of your day. Bye.